quite honestly, the major problem with Degarelix is the monthly injection, and they haven't been able to get past that from a technical standpoint and from a logistical standpoint. At least in a referral practice like ours, where patients travel relatively long distances, nobody's been particularly interested in coming every month for an injection. And for us in our practice, that's been the biggest barrier. We have some patients that we've transitioned from agonist to antagonist therapy if they did not achieve a castrate level of testosterone on an agonist. That's another option rather than orchiectomy, which has sometimes been effective. The whole concern about microsurges and all that sort of thing, the microtestosterone surges, I'm not sure how much that really translates to clinical difference, but I do think the crossover study that has been done is interesting. I don't think the state of the evidence would really support kind of using an antagonist preferentially over an agonist long term. I know some people use it as a transition. They start with the antagonist and then transition the patients to an agonist. For most patients who are starting on hormonal therapy in contemporary practice who just have a detectable PSA or very limited burden metastatic disease, I'm not sure how important the flare is from a clinical standpoint. There have been some secondary analyses done suggesting less of a cardiac impact or a metabolic impact from the antagonists compared to the agonists. I think it's very interesting, but again, definitive studies haven't really been done yet.